Today I will be discussing our admission forms and how we keep track of our patients' records. So we can take a quick look at it. This is for new clients. We would get our owner's name, address, cell phone number. We would see how they heard about us, and then we would get our patient signalment. We'll get the patient's name, how old are they, their species, their sex, whether spayed or neutered, their breed, if they're microchip or not, and then authorization for us to take care of the patient as well. Now our records are kept online, so it's all digital, but here we can see Lulu's signalment. We have her ID, how old she is, how much she weighs. She's a spayed female. We also have her breed. We know that she's friendly. We can also go into detail on her owner's name, then again her weight, her rabies number. If she had a microchip, we would have her microchip number right here, and just more overall information. If we had any specific notes to take care of, like she likes to take treats, just information about her so that we can do our exam or take in our patient, give them better service. Here in her clinical records, we can see all that she's been through. If she has any existing medical problems right here, anything to take care of, we can see her standards of care, what vaccines she's due for, which ones she's not. So now here is an example of how we would do an admission for a patient. We have her weight, we would have her temperature, respiratory rate, everything here. This is where we would put it. We ask a few simple questions just to get a history on how she's been doing. This is for her annual, so we can see she's had no coughing, vomiting, diarrhea. She's had no problems urinating or defecating. She's on heartburn prevention and flea and tick prevention, as we saw right over here. She's taking her Revolution. We can see what she eats, the brand, and then owner sometimes gives her a little bit of meat. She's mostly inside. We can see just overall questions about how she does. We can know what technician took the history. In this case, I did it. And then we can see the doctor's notes on Lulu, what she found, her eyes, how they look, her respiratory auscultation, her palpation on her abdomen. We can see everything in here. So clicking here on Lulu's information, on her clinical records, this is where we can see that everything that's been done in the past, all the history that we have from her. So here we have like her dental, we have her annual, which I was talking about. If you click on it, we can see what we did, and then the blood work that we did on Lulu as well. So we can see that here. If we wanted to see like previous, like this is she came on November for a Bordetella. We can see here on we can see that she came on May, and we can also see all the blood work that she got from last year. She was heartworm negative, no parasite, no intestinal parasites. We can see all the other blood work that we've done on her fecal, and so on. So this is where we would go to find our patient's clinical records, and we would just keep track of them here. So this is also online. So we would actually print this paper form, the physical copy, and have the patient sign it, and then we would just scan it and then we would transfer it into our computer system again, so we would have it attached. This is Lulu's file still, so we would have it on her attachments. And we're looking at her release consent form for her dental, and this is what it looks like. So we have again owner's name, her address, the phone number. She added an extra phone number just in case. We have her weight, then her name, again her signalment, and everything here. We have you know, the anesthetic procedures that are going to be performed. We have, you know, we make sure to talk to the client about whether Lulu has eaten after 10 p.m. last night, and she hasn't had any medications either. Any other concerns? We have here that she gives permission to do CPR in case we would. She also authorized for dental extractions if needed. That way, if there's anything else that we need to remove. She has previously been given an estimate where we show her about how much she would need to pay. Even with extractions, we have a low end and high end, so she knows the maximum amount that she could possibly pay if we were to remove extractions, and she knows it's not the definite price. We won't know that until we actually do the procedure. She has prefer that we contact her at the number listed before any extraction, so we're still gonna give her a call before we begin. That way she knows how many teeth we are pulling, which ones we are pulling, because she doesn't necessarily know. We don't know either until we get there, but it's important to let our patient or our client know exactly how many teeth we are pulling and exactly where the teeth that need to be pulled are. That way she doesn't we don't have any surprises on the time of pickup. This is what our cage cards look like. This is our patient Montgomery. He's staying with us for boarding. Here we have the date that he came in and the date that he's gonna get out. He doesn't have any procedures to be done on him, but if we had to do an exam or any other type of services, like if he was getting dropped off for an exam or a dental or a neuter, we would input that in here. If he's on any medications, we would highlight this and put our medications he needs. If there were a lot of medications, a lot of things to keep track on, we have a separate page where we would show what medications he's taking and at what time of the day. Here we have the kind of food. He brought his own food, and we can see his belongings. We put him on a bin under their kennel, so I have highlighted what bin his belongings are, and what else he came in. He came with a food in his plastic container. We're supposed to feed him 3 times a day. We can also see that he's a really friendly guy, so it's easy to approach. We can see his breed, how old he is. He's a male, and then here we can keep track of his feeding times. He came in the afternoon, so we can see initial whenever someone feeds him, and whenever we take him out to make sure that he's urinating and defecating well. Now for Lulu, we have laboratory forms, so we can get some blood work before we started her dental. This is and what we have here for Miss Lulu. We can see her hematocrit, her red blood cells, white blood cells, all her values here, making sure that everything looks good before we start the procedure. We also, so this is where we know she got her lab test. It was a CBC, and then she also got her chemistry, and you know, we got her glucose values, SDMAs, potassium, and we can see that her total protein is a little elevated, but it's not way past normal levels, so she was still considered a good candidate for that dental procedure. Here we have our anesthesia forms, so this is where we have documented what we used for pre-anesthetic. We used Torb and dextrometer. We have how much we gave, and then we have the route we gave it. We have the initial of the technician that gave the pre-anesthetic and at what time we gave it. We also have that we gave her Remedil somewhere at the beginning of her procedure, and we also have how much propofol we used and at what time we gave it for induction of anesthesia. And then here we have records of the monitoring of her procedure. So it lasted from 11:02 to 11:25. So just a couple, less than half an hour. We have here the amount of fluids that she received when her procedure ended, and we also have here records on where she was kept, and here we can see her heart rate throughout the procedure. We did use dextrometer, so at the beginning her heart rate was a little slow, but then she stabilized. So here we have our post-dental care for Lulu after her dental. So we have a little bit of notes to talk to the client about. We have information about the anesthetics. We also talked to them about how she might be nauseous even after the procedure, and it's perfectly normal to feel a little bit down for the afternoon. She might not want to eat as much, and we still, even so, we recommend feeding her just half the amount that she normally eats. And then if she does not eat, that's a possible side effect. If she doesn't want to eat tonight, it's fine. Just let us know if it continues throughout tomorrow. We also let her know that her teeth are going to be a little bit sore after the procedure, especially since she got some teeth extracted. We did give her Remedil for the day during her procedure, so she might not be as painful, but if there is any abnormalities, bleeding around the suture area, swelling, any vomiting, very abnormal, then yes, we could be notified immediately, so we can do something about it. We are also sending her home with gabapentin and more carprofen, so that we can help with her pain. She's gonna be taking carprofen starting tomorrow, since we gave an injection of that same medication today, so she doesn't need that today. So she should start tomorrow. She's gonna be giving 1 tablet by mouth every 24 hours for the pain and inflammation, and then we're gonna give 1 capsule of gabapentin every 12 to 24 hours as needed, just for the pain. And then just let our patient know that our client, if they have any questions, any complications, any lethargy, vomiting, anything that they can think of, that they can just call us, or just let us know. That way we can help address the problems if there are any. Today we are going to be showing how to do a restraint for a jugular blood draw. We are going to hold the patient's legs straight down, and then hold the patient's muzzle and head up like that, straight forward, according to however the person that's drawing blood wants them, and have the neck exposed so that they can draw blood. Today I'm going to be showing how to do a restraint for a cephalic blood draw. So what we want to do is keep the head away from the person that's going to be drawing the blood. We're going to grab the leg of their choosing, and then we're going to roll back the vein, and keep your hand, some of your fingers behind the elbow to keep the arms straight, and that way they can draw the blood. Today we're going to be showing how to do a restraint for a lateral saphenous on a dog. We are, again, keep the head away from the tech that's going to be drawing the blood, and we are going to have one of our hands around the close to the stifle and just apply pressure so that they can draw blood from the vein right here. And this is how you do a restraint. Today I will show the proper way to get an animal out of the kennel. So we are going to be approach at an angle. First we want to read the animal, make sure he's friendly enough to approach. I'm going to stand at an angle and stand in front of the door and try to not corner the pet, but also do not give it enough space for him to get out when I open the door. So when I open the door, use the verbal reassurance. Hey, radar. Seems like a friendly cat. We're going to approach for cats. We want to scruff and then pick them up, and this is how we take them out. To take them back in, we want to get their face away from us and move them head first into the kennel. Again, same thing, do not leave enough space for them to get out, but do not corner the pet either. For more aggressive cats, we would use a towel to be able to get them out, maybe wrap them up. Same for small dogs, you could also use a towel, and for the larger dogs you can use a leash to wrap around their heads before you take them out of the kennel. Today we are going to show how to properly apply a muzzle. So we are going to have our muzzle with the thicker part facing down and the thinner part facing up. We are going to sneak behind the dog through the muzzle and behind the ears, and then we're going to snap and pull it tight. Just tight enough so that he can still take his tongue out and be able to pant. And this is how we properly apply a muzzle. Today we are going to be showing how to properly apply an e-collar. So we are going to again make sure that his nose is still in the area of the collar. We're going to tighten it up, make sure that you can fit at least 2 fingers in your collar to make sure that it's not too tight. And this is how we would apply it. I think this one might be too small, but it's the same rule for all of them. Just make sure that his nose, it touches the point of the edge of the collar. Today I'm going to be performing a physical exam on a dog. We always start by looking at through the head, just looking at her eyes, her teeth. They're a little bit bad since she is an older dog. We can always try to feel the lymph nodes, but over here they're usually under the salivary glands. Normal size. Alright. We're also going to be taking her pulse on the Alright, we have a good pulse in 90 of 90, and then we are going to be listening to her lungs and her heart. So the best place to look, listen for her heart would be on her left side. Alright, and it's about 120 beats per minute, which is perfectly normal, especially for a small dog. She does have a heart murmur. It's level 3, but she seems to be doing pretty good. And then we also got to listen to her lungs. and her respiratory rate is at 30 breaths per minute. We're also going to take her temperature. So if we get her on the side. Alright, it looks like she's at 101.1, which is perfectly normal for a dog. Alright, so she looks pretty good. Also, capillary refill time, pretty good, under 2 seconds. And this is how we performed a physical exam. Looking at her, because of her heart murmur, we would say that the ASA grade for her would be around 2. Today I'm going to be showing how to do a physical exam on a cat. So it's actually facing this way. First we want to take a look at the eyes. Also, if you let us, we can look at the teeth. Check the capillary refill time. Good. Try to fill the lymph nodes. And this side as well. Okay. All normal. Well, listen to the heart. For cats, it's easier if you listen closer to the apex of the heart, and he's really nervous and it's beating really loud and fast. Look. So we're at 130, which is perfectly normal for a cat. And we also listen to his lungs, which is at about 100 breaths per minute as well, because he's really nervous. All right. It's okay, baby. Lastly, we're going to take his temperature. We're going to make sure to scrub him real well. You might not like this. We have applied lube to our thermometer already. Alright, it's at 102.1, which is perfectly normal for a cat. And looking at his pulse, heart rate, respiration, perfectly normal. His ASA grade would be 1. He's perfectly healthy. So if we had to do a surgical exam, a surgical procedure on him, it would be perfectly fine for him, since he's a perfectly healthy cat. Today I'm going to be showing how to get blood from the cephalic. We are going to, we have our restrainer holding off on the vein. I want to apply a little bit of alcohol, and then with our syringe, breaking our seal, place your hand next to the vein. And then just slowly withdraw. Once you finish, apply pressure on the hand, and the restrainer can let off. And then we have some blood right here. After that, we apply some pressure on the site where we drew the blood. That way she doesn't get a hematoma. Today I'm going to be showing how to do a jugular blood draw on a dog. So we have our dog restrained, and then we're just going to apply some alcohol. So we're going to apply pressure on the jugular furrow. We're going to fill the vein, and then with our needle bevel up, we would insert. And then once we finish, we let off and we hold on. And this is how we get blood from our jugular vein. Just make sure to apply some pressure after you draw the blood. That way she doesn't get a hematoma. Today I'm going to be showing how to draw blood from the lateral saphenous vein. So we have our patient already in position, and our restrainer is holding there. We have our needle. Alright, and then just make sure once you got your blood to hold off so that you don't develop a hematoma on the dog. So today I'm going to show how to draw blood from the cephalic vein on a cat. So our restrainer is going to hold off on the vein, and we are going to apply some alcohol. Okay. It's okay, Luke. Good, Luke. Break our seal on our syringe. Feel the vein. Look, look. It's okay. Look. And then slowly draw back. Look. It's okay. That's all I need. Oh. Make sure to hold off again on that vein, and then Alright, so this is how we get a jugular blood draw on a cat. Once we have our blood, make sure to hold off on the vein so that our patient will not get a hematoma. Today I'm going to be showing how to draw blood from the medial saphenous vein. We have our restrainer right here. Make sure to hold the leg. We're going to apply some alcohol. We're going to break the seal on our syringe. With the cap. And then we are going to slowly draw blood. Alright, that should be enough for the demonstration. So just remember to hold on to the vein right after you draw the blood so that you don't cause a hematoma on the minimum of databases that we need to get from our patients would be, you know, a CBC, their hematocrit, the total solids, and we can do those here. Just do a regular CBC with our CBC machine, or a blood smear and do total solids with the refractometer. We also recommend getting their chemistry, at least getting to know their glucose and ALT and ALP levels to make sure that there's no liver problems. If there were, we would know that the patient would not be okay during anesthesia, and then we would measure the pros and cons and whether the patient would be good candidate for being under anesthesia. So it's really important to have those, make sure that the liver is safe, but those are our minimum values, and here we can see some of the extra values that we could have on top of that, and of course heart rhythm tests and fecal tests. Those are also good to have, just a little bit of extra stuff that we can also do for our patients. Today I'm going to be talking about additional databases that might be needed after we perform a physical exam. So what we could always do is just lab work. We always recommend that annually for our pets, just to make sure that they're healthy overall. But we also have you know, just a regular CBC and chemistry for our basic values. And then if we have a patient, like if we have a cat that's really skinny, eating a lot, or any doubts that we might need extra lab work, we also have lab work that can be sent out specifically for thyroid values. We also do urinalysis if we suspect a bone fracture or any our patient might have eaten something they shouldn't have. We can perform radiographs, ultrasounds as well, just to make sure that we find whatever the cause it is. If they eat something, if they're constipated, if they're throwing up a lot, we can also do a barium study. We have different kinds of other procedures that we can do going off from what our patient might be having. We can also do an ECG, make sure that their heart is working well if we think that there's any problems. We can also run some blood tests just to see how they are doing. We can also do ear cytologies, make sure that there's no ear infections, things like that. We can also input that on their profile. We can also do just heartworm tests. If we suspect any heartworms, we can do the ELISA test. We can also just do a smear. If there's a suspicion of heartworms right then and there, we have a really, it actually has happened in this clinic before. We had really lethargic dog, and that's something that we suspected, and it was. There's just a lot of other additional databases that we can take care of if we suspect something from our patient if they are not feeling well. There's a few things that we cannot do here, but we can always get a sample and send it out to see if we have any answers aside from what we already from what we can actually do here. So today I'm going to be talking about the pre-anesthetic and the pre-anesthetic protocols that we use in our clinic. I had a discussion with our vet, so we can talk about the methods that they use to choose what kind of pre-anesthetic medications they want to use, and how they want to induce their patients. So that's what I'll be talking about today. So for example, our vet likes to use a combination of Dex and butorphanol. She believes that it has a good sedative effect on the patient, and it has a little bit of analgesic on it. So for average procedures, just such as the dentals, she likes it. It helps her, and especially because it helps reverse the effects with antecedent or anything. If there's any complication, there's always a way to reverse the drugs. Now for it's not used every single time, but it's important to remember that everything depends on the patient's blood work and then what the vet is more comfortable with. So every vet is going to be a little bit different. They're comfortable with different things. We have another vet that likes the combination of ACE and buprenorphine instead of Dex and Torb. It's up to them, but it's also it's mostly up to what the patient's conditions are. So first of all, before we do anything, we like to have some blood work on our patient to make sure that there's no liver failures. If there's any liver problems, we would most likely not go ahead and do surgeries like that, especially not like dentals, things that are not the cons will outweigh the pros will outweigh the cons on what we're doing, since most of these drugs will always be metabolized in the liver, so we don't want to do that. But we gotta make sure that our patients, wanna keep in mind our patients are healthy. There's no heart problems, there's no anemia, things like that. All of that can change what the doctor will choose to do. Also, their age is really important. If they're too young or too old, we definitely don't want to use dextromethorphan on a really old patient, or ACE as well, and a really young animal, or usually cats. Not very convenient. Also, ketamine, you don't want to use it in cats. So their species, their age, their condition, their body condition, and everything is very important to keep in mind. Another thing that we also keep in mind is what kind of procedure we're going to be doing. An interesting thing that I talked about with the vet is depending on what kind of surgery you're doing. If you're going into the gastrointestinal system, sometimes buprenorphine might be better to compensate for the pain, as opposed to butorphanol. We have epinephrine. If there's going to be a lot of bleeding, there's a lot of things that we gotta keep in mind. Another thing, if we have patients with heart murmurs, our vet usually likes to try midazolam, as it helps. It's kind of cardioprotective. Also, have it mixed with it's a good induction agent, so she'll like to do that. I know we've done a dental on a few patients with heart murmurs, and these are the drugs that we use to pre-medicate and induce our patients. So like I said, it's always up to the vet what they're most comfortable with, but mostly what the patient requires. So I'm going to show how we input controlled substances onto our log. So first we would input the date, like so. We are not actually inputting a real patient in here, but if we were, we would just put the name of the patient. For the purposes of demonstration, we're just going to do it like this. We are doing diazepam, so we would put the reasons why we're using it. And then we would put the amount that we use, so we could put like whatever amount, so I'm just going to put like 1. And then here at the top, we always keep track of what we started with. And then we would just subtract it from it, and then we just put how much we have remaining, and then we would initial at the end, and that way we can keep track of our inventory. Today I'm going to be talking about the anesthesia machine and the parts that compose it. On the side right here we have our gas tank and the pressure gauge. Tells us how much gas we have. Right now it's off, and all the our oxygen is going to be shown on the flow meter, which is this one right here. It is measured in liters per of gas per minute. So according to this, it'll show us how much oxygen we're giving to the patient. Here we have our flush valve, which I'm going to turn the gas tank on. And so we have our flush valve, which is right there. The flush valve will deliver the oxygen. So it's going to bypass our vaporizer, which I'm about to talk about, and it's also going to bypass the flow meter. Here we have our vaporizer. As I said before, we use isoflurane, so this is where we input the liquid isoflurane, and it'll vaporize it, turn it into gas. With this, it has a security button that we press, and then we can dial it to see how much percentage of isoflurane you want to give to a patient. This is the input and output lines where the gas enters. This is where pure oxygen comes in, and then the oxygen mixed with the isoflurane goes out, and it goes all the way back right over here, so that it could be directed out into our breathing circuit into the patient. So that's our vaporizer. Now the gas is going to be going through our right here. I have a rebreathing system, but we have our unidirectional valves. This is our inhalation and then exhalation valves, they go just they're unidirectional, just go one way. So this one shoots out just the oxygen, or the oxygen mixed with the anesthetic, and then our patient will breathe it through what we see as the blue tube. Now remember, this is the rebreathing system. That's how this one works. And when the patient exhales, it goes back through the clear part of the tube all the way through this other clear part, all the way out. And then here we have our reservoir bag. This is how we can monitor the respiration. It'll inflate and deflate to show us how our patient is breathing. Yeah, we also have our manometer, which tells us how much pressure our patient is getting in their lungs. Right here we have our pop-off valve, or pressure relief valve. This one actually turns, but some of them are in different, it can be in a different position, but they're all the same thing. We want to make sure this one is always on or open when our patient is breathing, because if we have it closed, it could cause a lot of pressure to be built up on the patient's lungs, and that could be really dangerous. We only want to have it closed whenever we are bagging the patient ourselves, which we would turn it off, and then our bag will inflate. We should never let it go over 20 centimeters of water, which we can see in the manometer. But then we would just press on the relief valve to give the patient oxygen, and then pop the pop-off valve on again. Right down here we have our carbon dioxide canister. This one, it helps absorb the carbon dioxide that our patient is exhaling. It's gonna go all the way here. We have the soda lime granules, and they turn purple whenever they need to be changed, either way every month, or whenever the granules start to turn purple, because it could be dangerous. If we don't do it, our patient could be rebreathing the carbon dioxide that it's exhaling. Last thing we talk about is our scavenging system, which consists of activated charcoal canisters. These need to be weighed after every use. They get heavier after every use. They absorb the anesthetic waste. So here we have our tracking of it after every use. We initial it and we put how much weight it is. After it weighs about 50 grams, we change it to a new one, or after we've used it for 12 hours. This way we make sure that no anesthetic waste keeps building up on our that our patient is rebreathing, and it doesn't go out and the personal breathes it. So now we already kind of brushed through our rebreathing system, how it connects to our unidirectional valves, and our patient breathes in and out throughout the same tube. So for patients that are smaller than that weight less than about 15 pounds, we don't want to use that. That would be too much effort for their lungs to be breathing in and out through the same tube, because remember that this one is mixed with the patient will rebreathe a little bit of the same anesthetic gas that's being recycled. But for patients whose lungs are too small to do that, we use the non-rebreathing system. This one, the patient will breathe in through the tube and through one tube, and exhale through another tube. That way, no oxygen is getting recycled. Our patient would be getting 100% fresh air every single time, and it comes with its own reservoir valve bag, and its own kind of pop-off valve, which opens and closes. So the way we would attach this non-rebreathing system into our anesthetic machine would be we have a tube that's going to be taking our gas, our oxygen, and isoflurane into our patients. So we would take it from the unplug the output from our vaporizer and plug this one in its place. Then our oxygen and ISO would be taken to our patient. This is where the endotracheal tube would be plugged in. Then our patient, we would exhale through this tube, the reservoir bag, and then we would connect this one right here to our scavenging system, our activated charcoal. It would be plugged in here. That way we get rid of the anesthetic gas. Another thing to consider with our anesthetic machine, aside from our rebreathing and non-rebreathing systems, we also have gas chambers, which we don't have at this clinic, but they would be kind of like a plastic-ish box where we would put the animal in, usually similar to this rebreathing system. Like you would just hook it up onto that gas chamber, and then the gas would get in the box exclusively. That way only the animal is breathing the anesthetic gas. Some of them will even have a place that hooks in and pushes the anesthetic gas in, and something that pushes it out. That way, whenever you open the chamber, it's not as saturated with anesthetic gas. Another thing to use for PET induction using the anesthetic gas is a mask, which we have right here. We have different sizes to accommodate to the PET. You usually put it in their muzzle, and you would hook it up to your breathing circuit, like so, and then the animal would, you know, their face would be in there, and then that's how they would be getting their air. Usually this happens when we cannot intubate the patient, and then this is the next best thing for induction. So that is two other things to keep in mind. Of course, they're not as safe as using your rebreathing or non-rebreathing system, because more anesthetic gas can come out of the chamber or around the mask, but those are other things to keep in mind. So today we are going to be doing a leak test on an anesthetic machine. So we have our tank on, our vaporizer is off. What we're going to do is I'm going to put my hand on the opening of the non-rebreathing machine. We're going to push our flush valve, and with our pop-off valve off, we are going to get our manometer to read about 20 centimeters of water. And I can show our manometer. It's right here. It's kind of hard to see from the front, but it's right here. So it would read about 20 centimeters of water. So that's what we are going to do. So I'm going to place my hand right here. Make sure that it's at around 20, and we're going to wait for about 5 seconds, just like this. If the arrow on our manometer went to go down during the next 5 seconds, we would know that there is a leak, and then we would look for it and find the problem before we start using our anesthetic machine. There was no decrease in our reading on our manometer. So what we're going to do is just open our pop-off valve, just so that we make sure that it's always open before any procedure, and then we can finish with, and then we are done with our leak test. So here is a demonstration of how we would use the pulse oximeter. The pulse oximeter will indicate how much oxygen, saturated oxygen, the patient is getting in the blood. It uses a red light and infrared light to measure, to read the blood on the arteries, and we just put it either on the tongue or any hairless part of the body that would be easy for it to read, because the fur can prevent the light from reading through the arteries. And we can see here that the level of oxygen that the patient is getting is 98, which is perfectly normal under anesthesia, and it should never be lower than 95. So, hold it. So I'm going to show, this is an esophageal tube. So the way this works, we just pass it down our patient's throat. Well, and then we plug it into our earpiece, and then we can actually listen to the heart. So I will show how to insert a feeding tube on our dog. Open the mouth, insert like so, and then we'll be able to input either barium or whatever it is that we want to reach the stomach. Today I'm going to be showing how to attach the leads to an ECG machine, the electrocardiogram. So after we apply a little bit of alcohol on all of our leads, it's just not too much, just a little bit. And we can see it here. A way to remember it is the red one under the black one, smoke over fire, and then the green one under the white one. It's good to have our patient in right recumbency when we're doing this, and a way to prevent artifacts is make sure that the patient is not moving too much, and there's nobody moving the leads, as well as no electrical equipment close to the patient or close to the leads. That way we can prevent artifacts. And then we can see here, the more stable the patient is, the best results we have on our readings. This is an endotracheal tube. Now, this is used to intubate a patient, so we can connect him to gas anesthesia. So they come in different sizes. One way to kind of check for the size of endotracheal tube that you're going to use is to look at the patient's nose and kind of measure it like in the middle of their in between their nostrils. Just put it like that on a patient, and find an endotracheal tube that fits just right in that middle septum of the nose, and find one that fits in that little the middle of their nose. Now it's not always going to be that accurate, so you want to have backups. We want to have once we pick, like for example, I have a size 6, we want to have a 5.5, and then we're going to have a 6.5. So half a size down and a half a size up, just in case. Just have it ready at hand, just in case this one doesn't fit. Now the endotracheal tube, we want to inflate the cuff by getting a syringe, either a 12 mil or a 10 mil syringe, and we are going to hook it up to the cuff and then just slowly inflate. And we want to do this before we intubate the patient as well, because we want to make sure that there's no leak in our endotracheal tube. So if we were to fill it up and then it deflates on its own, we know that it's not right to use on a patient, that because it's probably going to deflate once it's inside our patient's trachea. So we want to make sure that all 3 that you chose are inflated. Now to check for leaks, we can also have here a little bit of soap water, or soapy water in this here, and either and before we use our endotracheal tube, you can also I'm deflating it, but put it under the water and then inflate your cuff as the other end of the endotracheal tube is inside the water, and watch for bubbles. If there's any bubbles coming from the endotracheal tube, it means that there is a hole somewhere. So that's an easy way to see that it's not ready, that it's not good to be used. Now, also with our endotracheal tube, once our patient has been intubated, if you wanna, we wanna make sure that the endotracheal tube was big enough or wide enough to prevent any air from coming in or around, coming around the endotracheal tube, because if this is the case, then anesthetic gas can actually be expirated from the patient, and the patient could also be just breathing regular oxygen with no anesthetic around the endotracheal tube, which makes it harder for your patient to be anesthetized. So once your patient is intubated and you made sure that there is no there's no hole or any holes on your endotracheal tube, one way to check for leaks would be, once your patient has been intubated and you inflated the cuff slowly, we can also close our pop-off valve and inflate the cuff slowly, and make sure that the pressure, once our pressure gets to 20 centimeters per water, we want to make sure that we press on the reservoir bag and see if the pressure keeps going up. That way we can make sure that there is no there is just enough, the cuff is inflated just at the right width of the trachea. That way there's no air coming in around the endotracheal tube. So that's how we would check for any leaks. Another way, once your patient has been intubated, if it's really obvious, you would be able to smell the anesthetic gas from the patient's mouth. That is also an indicator that your endotracheal tube is either it's not the right size, it might be that it's just too small or too thin, or you did not inflate the cuff enough. Another thing to remember, once your patient has been intubated and you make sure that there's no leaks, is to keep checking for that cuff to be inflated every 5 to 10 minutes. Just keep checking on it, because it could be that it will start to deflate, and we want to make sure that it does not happen. So every 5-15 minutes, kind of check, just kind of feel on the cuff, make sure that it's still good, and if it's not, just add a little bit of air, just to make sure that your patient is getting all the anesthetic gas that it needs. So our respiratory monitor is actually going to be our reservoir bag. So the way we do it is the reservoir bag will kind of show us, it'll inflate and deflate as the patient is breathing, and that's how we can get our patient's respiratory rate. So here we can see how our pressure, how it works. So we have it on our cat's arm or her paw, and then we press a button that will inflate the cuff right here, and then it'll show us our patient's systolic and diastolic pressures. It will also pop up the mean arterial pressure after a few seconds as well. To take the temperature of our patient, we use a rectal thermometer, digital thermometer, and what we do is we input the thermometer into a plastic probe in here, and then we dip it into some lubricant so that it makes it easier to slide into the patient's rectal area. And the way it works is you click on a button and it'll start taking the temperature. It takes a few seconds, and then it'll start beeping once it has the right temperature. Okay. And I am here to introduce my preceptor. This is Dr. Hageney, our Director of Veterinary Medicine. And I don't know if
I graduated from the University of Wisconsin in 2007 and have been medical director here at Valwood for 2 years.
Today I'm going to be placing a catheter on a dog, a cephalic catheter.
I'm trying to get this up for you.
Okay, and we're going to clean the area with Chlorhex and alcohol. 3 wipes. Okay, now we have a 22 gauge catheter. We're gonna flush. Okay, and we're going to go bevel up on the vein once we found it. And then we're going to get some tape. Around the furry layer.
Make sure it's not too tight, but not too loose.
We're going to use a second tape to go over it with the sticky side down. And we're going to flush to make sure we have our catheter in.
Do you have to show the whole prep or just the
Just the catheter
Placement?
yeah.
I've already done the induction on the intubating part. No, I meant you have to show your prep, like cleaning for your catheter and stuff like that. Are you recording this? And I made it so it doesn't record all the buttons.
arm?
Oh. Although truth. I think it's in. And that's it. So we are going to be giving candy pyramidal shot sub-Q. You just make a tent on his chin. So this is gonna be the injection IM. Okay. So I will be administering an IV injection. So first we are going to get some alcohol. Focus. Cookies. No. Cookies. Okay. And that's it. And at the end, we just make sure to hold on real tight. So remember, as soon as you see blood, you inject your medication. This was just saline, so she didn't really need one. Today I'm going to be showing how to do an anesthesia induction through propofol. So we already have our catheter here. We are going to slowly induce the patient with propofol. It should take about a minute to input the whole thing. We are going to be checking for the reflexes of our patient and the jaw tone. That should be okay. And this is how we do an induction for anesthesia. To input a endotracheal catheter, we have our laryngoscope. We're going to pull the tongue out and use our laryngoscope to guide us through. We're going to find the epiglottis and input the endotracheal tube in between the laryngeal folds. So now that we have plugged her into the anesthetic machine, we apply some glue in each eye. To inflate the ET tube, we would just input a little bit of air down the cuff and make sure that when we touch it, it doesn't feel too tight. Too inflated. And then to deflate the cuff, we would just suction the air out as well. So we're going to express our patient's bladder. So we're gonna locate it here and apply gentle pressure. We are going to shave our patient for her spay. So we are going to go from the xiphoid all the way down to the pubic area and about an inch away from her seats. I'm just gonna still let you sit. Oh, there it is. Today we are going to be scrubbing a dog before his neuter. So we have already shaved the area right here. So we're going to go in a circular motion, beginning with our Chlorohex.
Medical Directors Summit, and I sat next to the from class 2.
We're going outwards, trying not to go back.
Or no.
Anyway, she's kind of long. She has a lot. Shut up.
And then we're going to continue with alcohol.
I asked her, because curiosity, right? Like, how fast can you spray a cat? She's like,
So we're using one gauze with Chlorohex and one with alcohol. And always check after you wipe to make sure that it's clean. So this one's still a little dirty, so we're going to keep going.
was there much information
And
you just say it and like
thing with alcohol.
This is what I'm just gonna do with this right now. Just to keep it. And then like
sterile.
No, that's smart. No, actually. If they ever answer their phone, second phone is not one positive.
So I am monitoring for the surgery. It's been about 15 minutes since the surgery. We are checking for the heart rate and checking at their vitals. Is it palpebral or palpebral reflex and jaw tone, as well as our respiratory monitor right here every 5 minutes. Today I will show how to perform CPR on a dog. So the first thing to look for on an animal that needs CPR is they're called the ABCs. So you're going to check for, well, first we're going to check if the animal is responsive. You can call to the animal and see if it's aware of its surroundings. You're going to check for an airway if there's anything in the way of his respiration. If you open the mouth, you see something in there. For breathing, if the animal is breathing, and then circulation, which is you could take the pulse of an animal. However, this must be you do not have to spend more than 5 seconds looking for circulation, since this would delay an actual help that the animal would need, since they're obviously not breathing. For CPR, we would do 30 compressions and 2 breaths on the animal's nostrils, on the animal's nares, for CPR, we would do, for the CPR, we would do 30 chest compressions and 2 breaths on the animal's nares, closing the mouth really tightly for about 2 minutes, and then after that, check if they're feeling well, if they're responsive, and if not, then continue. After those 2 minutes, it's also a good idea to have, if you have help, to have somebody else help do the compressions instead. That way you guys can take turns, and if there is someone available, they can also intubate the patient. So for our round-chested dogs, or mid-sized to large dogs, we would have our patient, we would do the compressions on the highest point of the chest, which should generally be like here, and make sure we have our hands together, and our hands should be over our shoulders, and our elbows should be locked, and we would do the compressions. For larger dogs, it should always, the compression should be about 1/3 to half of their chest, so as to be a decent amount of pressure. For keel-chested dogs or smaller dogs, we would do the compressions again on the point of the kind of at the apex of the heart, kind of. So you would look at where the elbow meets the chest, and that's where we would do the compressions. For flat-chested dogs, we would actually turn them into dorsal recumbency and actually apply pressure and apply pressure on the sternum. As well with our hands. For cats or really, really small dogs, we would actually do one hand, which is what I would do for this patient. And again, we would do it close to the kind of apex of the heart where it should be, and we would actually just use one hand and just kind of wrap it around their chest, and that's how we would apply the compressions, like so. And it would be 30 compressions, and again 2 breaths on the nares. Have their mouth closed really tightly and keep them in that position, and then again, yeah, just remember to do that for about 2 minutes. The compressions, going back to the compressions, they should be around 100 to 120 beats per minute to be effective. And the textbook does say to a way to kind of keep the rhythm is to use the song "Staying Alive" by Bee Gees, and that way you can actually do the compressions at the right rate, so that it can be an effective compressions. Again, if the patient after those 2 minutes is not responding, we can also try one more time and just check to see if the patient feels well. Do not spend too much time doing so it should be like 5 seconds just to check if the CPR is working. If not, then go back to doing another cycle. If our patient is intubated, we could also use the ambu bag. This one's about the right size. They come in different sizes for bigger or smaller dogs. And so the way it would work is this end would go into the endotracheal end of the tube here, and that's where we would hook the patient up. And then depending on their size, we would just apply pressure just to give their 2 breaths. And again, it would depend on the size of your patient if you would apply more pressure than not, but we have to be really careful. If you apply too much pressure on the bag too fast, it could actually collapse the patient's lungs, so we have to make sure that we don't do that. So today I'm going to be showing how to scrub in for surgery. The first thing we're going to do is grab our gown pack, and we are going to open it. grabbing onto the folds like so. And then we are going to grab our gloves and carefully opening them, we are going to drop them into our sterile field. Like so. So now what we are going to do is use our scrub. It comes with a sponge and it comes with soap, and it already comes with a nail scrub as well. So the first thing we are going to do is turn our water, let it warm up. We are going to wash our hands, and we're going to grab the nail scrub and fill into the inner part of our nail. So we are going to start at our fingertips. We are going to start with this hand, and we are going to get the fingertips of our and then we are going to move with our, we're going to start with our index finger. We are going to scrub the side of our index finger, and then at least 10 times each finger. And we are going to move to our, to the other side. When we get to our last finger, we are going to scrub the length of our hand, and then we're going to move to the palm of our hand, and then we're going to scrub the side of our thumb, like that, and repeat for our other hand. And then to dry our hands, we are going to go, we are going to not lower our hands lower than our elbows. Now that we scrubbed in, we are ready to dry our hands. Now all of our, we're ready to scrub in to dry our hands. So what we are going to do is, with one hand, we grab our towel and get one side of our towel. Try to not let it touch any your scrubs or anything else. And we're going to start drying our hands first on one of our hands, and then move down to our arms. Now with our other hand, we're going to grab the bottom part of our towel and move it up and use it to dry our other hand. And then we are going to just drop our towel. Now we are going to grab our gown. So we are going to grab it completely facing us, and then just grab it from the tips and let it fall, and then carefully at this point we will get somebody to come and tie the back. Now making sure that we do not take our hands out of sleeves, we are going to use the gloves that we previously dropped into our sterile field and open them like so. So we are going to grab our first glove. We're going to start at our right, and we are going to have it facing with the fingers facing us. With the little sleeve that we have right here, we are going to grab the sleeves and kind of pull our weight in like that. Once we have it at a mobile position for our fingers, we are going to grab the second pair of gloves, and again facing you, we are going to do the same. Now that we have it like this, we can use our sterile gloves to touch our sterile gown, part of our gown, and kind of pull off our sleeve. Try not to get the darker part of your sleeve on the outside, since it's the one that's been touching the most, the more possible contaminated part of your gown. And this is how we would scrub in for.
So what we would do is grab from the little flags. And then our then we would be ready for surgery.
And for this, we're just going to lock into the incision. When taking care of exposed tissues during surgery, and another thing that as a sterile technician your vet might ask you to do is to keep the organs moist. So during an exploratory surgery, for example, we want to make sure that we keep the exposed intestines moist, usually with sterile water. We would have the syringe, and then every once in a while just spray it a little bit with sterile water. We should do this at an angle, not directly on top of the organs, and make it really light so there's no splashing of the droplets and anywhere else in the surgery room.
Alright, go.
Scalpel. Clamp.
So to put on our scalpel into our scalpel holder, we are going to use our needle holders and grab our scalpel blade and then just place it in there like so. And then to take it off, we would just grab it from the bottom and kind of move it away from the scalpel holder, and then just pull it up, and then just throw it into our sharps container. Today I'm going to be talking about the responsibilities of a sterile technician. So when you are in surgery, and it is your responsibility as a sterile technician to keep the area sterile for the doctor that is going to be performing surgery. It is your responsibility to, if something gets contaminated, to make it known so that it can be fixed As a sterile technician, it's your responsibility to to pass surgical instruments to the vet if they need it, to count the sponges of your sterile pack, to make sure that at the beginning and at the end of the surgery, to make sure nothing got left behind, keeping the tissue moist, maintaining hemostasis with the proper techniques, all while maintaining your own sterility. Remember not to, face your vet face to face. Your back is not sterile, gotta remember that. If for some reason there is a contaminated object, make it known. If let's say your glove gets contaminated, the thing to do is to immediately replace it, and this can be done preferably by the assisted gloving technique. I'll have somebody else help you put it on. If there really is no one else, there's also the open glove technique, where with your sterile hand you can place the other sterile glove in, which is not preferred, but if the situation calls for it, it's what you must do. If anything falls on the floor, get somebody to replace the instrument, or get it sterilized by flash sterility, all to make sure that there is no contamination on the area. And again, just make it known if you see something that someone else, like nobody else saw. It's still, if there is any doubt in your mind that something is contaminated, do not use it. Get something new. That way we always make sure that our area is sterile, all for the good of the patient.
And she go close because it just gets yucky. So all I'm doing here is kind of stripping off the fat and stuff with the, like the big dogs and stuff. There's no way that you can strip off enough of the fat and then
We're gonna throw away the trash. Put everything back where we found it. With our canal salt, it takes about 10 minutes to take effect, so we're going to let it sit. and then we'll come back and clean it up. In the meantime, we'll take out the trash and make sure that everything's back in its place. Now it's been 10 minutes, so we can clean everything up. Like I said, we have a place for our surgery and our regular laundry. And then we'll just make sure to mop our surgery room as well. Today I will be showing how to clean our instruments after surgery. So we're gonna have our instruments on a bin mixed with we use Chlorhix scrub mixed with warm distilled water. So here we have our instruments. So they are mixed in with the scrub, and what we're gonna do is we're gonna take our instruments and make sure the box lock is open on all of them, and we're gonna scrub away from us with a brush. It's important to remember that it should not be a steel brush, as it can harm your instruments. And then once we make sure that they are clean, we're going to have them submerged on some lubricant, also mixed with distilled water. So we're gonna have it in here, and here we have our lubricant as well. So yeah, we will just take every instrument, make sure that it's the box lock is open or unlocked. Grab our brush and brush away from your body, and make sure you get all sides. And then we will set them aside to dry, and then we can move on to sterilizing. Today I'm going to be showing how to prepare a surgical instrument wrap. We're gonna have our spay hook, and we're gonna take our instruments. And I'm gonna have them lay in the center of my towel here. Like that. Then I'm gonna make sure we have our scalpel blade holders. Edson Brown forceps, red tooth forceps, and we're gonna put them all together with some gauze. I have 10 and 10 in here. Just put them in the center, and then we're gonna have an indicator that is gonna turn. The strap is gonna turn black whenever we sterilize it, so that when we open it, we make sure that it's sterilized. Then we're going to take our towel, which has been kind of laid out in kind of like a diamond shape, and we're going to fold it back and then back again, kind of to make a flap. And we're going to do that with all sides. We're going to fold it like that really tightly, and then fold it back. And then if we have remaining flap, then fold it back again. for this side. Make sure it's really tight. And then fold it back again and again. And then the last time we're going to do this, we're going to fold again inwards towards yourself, and then the remaining flap that we have here, it's going to go in to the little pocket that we have in there. And that's the first part that we have here. Then we have another towel below it, and we're going to do the same thing. Have that remaining pocket where we are going to push it in there and just leave a little flap outside, so that whenever we need to open the wrap, we just pull from here, and then we can do that. Then we are going to take some regular tape. I'm gonna label it. This is our black spay surgery pack. I'm gonna put the date and our initials. Okay. We're just gonna put it somewhere visible, and then we're going to take another piece of this time indicator tape. We're gonna grab a little piece, and this one, same as the indicator that we put inside the along with the instruments, it's gonna have lines that are gonna turn black whenever it's sterilized. That way we know that it's truly sterilized. And today I will show how to prepare a gown pack. We are going to start by folding our surgery gown. We are going to lay it on the table like this, kind of facing you, as if so we're going to have it the front side facing you. We are going to get the arms in the middle, and then we are going to fold it from the sides inwards. Make sure that your flaps are out. Then we're going to fold this back like this. So we have it ready. Then we're going to fold the front inwards. And we're going to do an accordion fold, like so. And this is how we would wrap fold our surgery gown. So now that our gown is folded, we are going to lay another two drapes where we are going to fold our gown. So now that we have our folded gown, we're gonna place it here in the center, or a little bit lower to the center. We're also gonna get a drape, towel, sorry. We're also gonna fold it. Like that, so that the doctor can wash their hands when they're about to scrub in. And we'll put a indicator for when we sterilize it to make sure, so that when they open it, they'll make sure that it's sterile. What we're going to do is grab the bottom part of our drape, and we are going to fold it like so, and then fold it back. We're going to do this with the sides as well. We're going to fold them as tight as we can, and then fold them back to make kind of like a flap, so that it makes it easier when you're unwrapping the gown. So we're folding it with the triangle side looking outwards, and then we fold back. And then lastly, we get this back part, and we also fold towards the front, and we tuck the remaining flap in like that. Now we're going to do the same thing for another layer. Fold it with the triangle looking at you and then away from you, and then pull the point back. It's important to make it as tight as you can make it. And then we're going to do the sides one more time. So we fold them away from you, and then back. And this one as well. And then we pull it back. And then if there's like a remaining edge that is kind of sticking out, then you fold back one more time. And then we get the last side and we pull it. Make it really tight, and then tuck the remaining edge inwards like that. Now that we have our surgery gown pack, we are going to get a regular tape to label what it is. So it's our extra large surgery gown, and we're going to put the date and our initials, so that they know who prepared it. And we're gonna label it like this. And then with a special tape that's kind of like indicator tape, we are going to grab a small piece. We're also going to tape it on top of the surgery gown. The indicator tape and the indicator strip that we put inside with the gown, both will have a line that turns black when it's been, to show that it's been sterilized. And that way when we take it out of the autoclave, we'll know if it actually sterilized or not. Today I'm going to be showing how to use our autoclave. We have our packs that we just wrapped up here, and this is our autoclave. I already have a few other things in here that we can sterilize. So I'm going to input these two right here. Into our autoclave. like so. Make sure that nothing is actually out of the way of the trays. Make sure that everything is in there. Now this autoclave is a gravity air displacement sterilizer, and what it does is it contains sterilized water in here, and after I turn it on, it's gonna heat up to 250 degrees, and it's gonna sterilize our equipment. And after it does, the steam water will go back to sterilized water and go back to its tank right here. So it takes 15 minutes to sterilize. So first we're going to fill it up with our sterilized water, and it takes a few seconds. It's important to always use sterilized water, not tap water, because this can damage the sterilizer. So we wait until the water fills up to this little plate cover, and then once it has filled up, we're going to close the door and begin sterilizing. So like I said, it's gonna take about 15 minutes, so we're gonna set up a timer as well, and it's going to sterilize our equipment. Now it's important to take care of this autoclave, to drain it every week. So we have a compartment here that we are going to we would open, and then we would drain the water out, and then refill it with more sterilized water up here. And then we are required to clean it after every 25 cycles. And we have a little chart here to help us do that. This is a new sterilizing cycle, but after 25 cycles, then we have it marked in here. We clean it with some sterilizer cleaner. This is our sterilizer cleaner. The way to clean our sterilizer would be, after every 25 cycles, we would first we would drain our autoclave from and refill it with sterilized water, and then we would put some autoclave cleaner into the chamber with no other sterilizing equipment in it, and we would run a cycle. After that, we would remove the trays from the autoclave and clean those separately, and make sure that everything is clean, and then run another cycle and drain the water again. And after that cycle, we would drain the water one more time and refill it again, and then the sterilizer would be ready to be used. So I have just opened the autoclave. The 50 minutes are up, so it's important to make sure that when we open our autoclave, it's kind of hard to see, but there is this is where we can see the pressure. There is no pressure when we are opening the autoclave, and there's no more heat. Make sure that it's off before we open the door. And then it's steaming, so we're gonna let it cool off and leave it open like that until it's safe enough to take our items out. Now, to check if our items have actually been sterilized, now that we've taken them out of the autoclave, we have some indicators like the ones we put before we put them in, and they have the black marks on them to indicate that the instrument packs have been sterilized. What was that again? I don't know the today. They have been in for 2 weeks, so they are ready to come out.
It's up.
All done.
It's done. All done.
one other thing to note when taking out the staples is the dog that we took the staples out from had the staples for 2 weeks, so they were plenty of ready to come out. But if sometimes if you do it too soon, or even if when you do it at the you waited the whole time that you were supposed to wait, sometimes there might be some redness around the area where the staples are. If there's any discharge coming from it, that means those that area could be infected, and then you would let your veterinarian know, because they might not be ready to come out, or we need to take them out and clean the area and restaple it. Sometimes if it's too early to remove the staples, you will know like the area still looks tender, it still looks pretty red, and then it's important to not let the staples there for too long, because the opposite can happen. The skin will dry out around the area, and it will heal up around the staples, which kind of leaves a hole whenever you do take the staple out, or sometimes the staple can even bury itself within the layers of the skin. So that's another thing to keep in mind.